Okay, so welcome all the students of the third semester MBA HCHM, and this is your first counseling session. Welcome, and I would really like to thank RC Delhi-2 for taking this initiative for organizing the counseling sessions, contacting the experts, scheduling it, contacting you all, especially Dr. Rita and Dr. Ruby. So from the regional center. And we've already wasted some time, so please, I would request Dr. Mahesh Devnani, who is additional professor and joint medical superintendent in Department of Hospital Administration, PG JIPMER, to take his class. And this is a very small introduction for him. For us, he is a very, very important expert who has been the backbone of this program. He has been actively involved in its material preparation, its implementation process. He keeps guiding us in identifying institutions, in trying to us to establish centers in institutions. And besides that, he's a wonderful person, and I'm sure that you have a lot to learn from him. So sir, please start your session. Thank you very much.
Thank you very much, Dr. Ruchika, for these kind words, and it's always a pleasure to having association with the IGNOU and association with you, and the wonderful work that you are doing, and trying to connect everyone and the different parts of the countries for the benefit of the students. So thank you very much, and I'll try my best to justify what you have said. So let's start. As I have been told that there are two units in the Block-3 that students are especially interested in understanding more. That is the Unit 11 and Unit 12. So that I will cover first, and then if time permits, I have material for the Unit 9 and Unit 10 also. And we'll have ample time for you to ask questions. As Dr. Ruchika said, if there are some questions that are unanswered, we can answer them later on the email as well, and during the next interaction, because I have 4 counseling sessions scheduled. So in any future counseling session also, I can take questions which are unanswered. So the session first I would like to start is with the quality management and accreditation process, and is one of the important aspect of the healthcare delivery. We wish to make patients healthy, right? Firstly, we want to prevent diseases in the healthcare, or the ailments or the situations. But once patients are ill, the treatment that we want to provide, or the management that we want to provide, and treatment is just a small portion of the whole management of the patient. We want to wish that it should be a quality management, and the patient also wants a quality management. So, but how do we define the quality? What is quality? So the foundation of healthcare quality and the WHO also have the same definition, which says that the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with the current professional knowledge. Now I would now like to emphasize on 3 aspects here. One is the individuals and the populations as well. The desired health outcome and the current professional knowledge. These 3 portions of this definition are very important. That when we are talking about the quality in healthcare, we are not just talking of quality of a particular procedure, quality of a particular unit, or a department or a hospital, but we are talking it at the community level. It includes everyone. It includes the smallest procedure that we perform, because that will decide the overall quality of the healthcare services that we are providing. When we are talking at the national level, we say how good the qualities of healthcare of the nation is, and then we piece it further. We reach to the smallest unit of the healthcare delivery. So it includes both individuals as well as the population. Second is the desired health outcome. I mean, we are setting a standard or a desire that this health outcome we require, we want to achieve. And efficiency is equally important in achieving that outcome. And that outcome has to be consistent with the current professional knowledge. That means the evidence-based management, evidence-based quality management should be there, so that what we are providing may not be the best, right? We would aspire to provide the best, but it should be consistent with the current professional knowledge, the evidence-based, and that is the foundation. Evidence-based medicine, I always say, is the foundation of the healthcare delivery system. So let's deconstruct it further. So who is the target? The delivering services tailored for both individual patients and the broader population. Especially when we are talking of the public health, you must have heard about the public health standards that are there in this country. And when we are facing with the epidemics and pandemics, then we set some standards and we want to achieve. For example, let's say if we want to achieve a vaccination, what is the target? By what we want to achieve, how much of herd immunity we want to achieve. But focusing it on the healthcare as an health administrator or a hospital administrator, we focus on the quality that we are providing in the hospital to the individuals and at large at the and largely to the community. And this quality is not just limited to indoor services. It includes the quality in the outpatient department, emergency department, the operation theater, each and every step where the patient has any type of contact with us. We wish to provide that quality. And how do we provide that quality management? That is what we are going to discuss in this topic in the next hour and a half. And the accreditation process, how it helps the healthcare providers in achieving those objectives. So the trajectory is actively increasing this statistical likelihood of the desired health outcome. And the standard is maintaining strict consistency with the current peer-reviewed professional knowledge. And when we combine all these, they actually lead to the operational quality. So this evidence-based protocols, the performance monitoring, and the continuous refinement is basically a bridge that connects the current clinical outcomes with the desired health outcomes. When we reach to the desired health outcomes, we say, okay, we have our outcomes are, quality outcomes. We also need to understand that while we are desiring those quality outcomes, a lot depends on the quality processes as well as the quality inputs. So if the inputs are good, if the processes are good, and then the monitoring is also good, then only we will be able to achieve the desired health outcomes. So the quality management is the structural bridge of current professional knowledge, spanning the gap between the baseline reality and optimized patient outcomes. Now, there are multifaceted impacts of the quality, and let's start it with the patient care. Why we need to, even care about the quality. We may be providing healthcare, but why should we be specifically concerned about the outcomes of our interventions, outcomes of our services? Because it actually improves the patient care. Adherence to the clinical guidelines, reduced medical errors, and enhanced safety outcomes leads to improved patient care. And I always say the very reason for existence of hospitals of healthcare delivery system is the patient. And the patient is at the core of anything we design, anything we strategize, anything we want to do. We must keep the patient in the center of everything that we want to do in the healthcare. And second thing, which many times we health administrators are more concerned about, is the operational efficiency. We want to achieve something, but we want to achieve that in a time-bound manner with optimal resources. So there is no wastage of resources. There is no wastage. This resource could be a time. If the waiting time of my outpatient department or my some lab test is more than the industry standard, even if my test results are best in the industry, it still may not be the meeting the quality standards of that operation, because we are having a larger or more waiting time than the industry standard. So operational efficiency, streamlined operations, reduced waste, and optimized resources utilization leads to the cost saving also. Many times we people who are working in the government setups or public sector undertakings are not concerned about the cost saving. But in the private sector, those who are working in the private sector, they need to be very cost aware so that they can survive. And healthcare is a very cost intensive industry where the input cost is quite high. Then it leads to regulatory compliances also. Some are the mandatory regulatory compliances, and some are that we voluntarily adapt. For example, accreditation, we adopt that and then say that we will comply to those requirements. So meeting accreditation standards to avoid penalties and maintain institutional reputation. Then staff morale and retention. No one wants to work in a hospital where quality is not good. The reputation of a hospital is not good, right? No one would like to, associate with that hospital. So attrition rate would be high if the staff morale is not good. So that is again will lead to inefficient operations. So creating a positive, secure work environment that attracts and retains top healthcare professionals is equally important in one of the dimensions of the quality management. And patient satisfaction. Ultimately, many times we discuss about the patient delight. It's not just that the satisfied patient, we want a delighted patient. A lot is associated with a lot of it, the satisfaction is associated with the way treatment has been given, and that is a lot, a major portion of that is technical. But there is another component of hospital, and that is the hospitality part of the hospital. And it actually adds to the
But the voice is cracking. The voice is cracking in between.
The voice is cracking in between. Okay,
Yeah.
let me see. How often is it?
It happened twice before, just now.
Okay. I think there is some internet issue. If it continues to happen, do interrupt me and let me know. If it happens for a brief period,
Okay.
then no. But if for let's say for a minute you are not able to hear, or for 30 seconds, then please do interrupt me.
Okay, sir. Okay,
Thank
sir.
you. Thank you. Sometimes internet might be, not stable. That could be a reason. So thank you. This evolution of quality management, there is a lot to teach. I mean, this an hour and a half discussing the whole Block-3 is not possible. There are multiple books, and on internet also you can see the way quality management in healthcare has evolved. A very small introduction of this has been mentioned in one of your manuals, and I have taken it from that the early 20th century, you must have heard of the Frederick Taylor, and later on the Deming cycle, and the Zuran, who actually were the pioneers initially, and they were not in the healthcare industry, right? So introduction of the scientific management and efficiency principle by the Frederick Taylor, the focus on the rigid standardization was there. The rise of, then there was this rise of total quality management, and later on the that we call the Japanese the concept, where we wanted that just-in-time concept was there. And then came the 21st century digitization now, where we talk about robotics, when we are talk of AI in the healthcare, and how it can actually help us in improving the outcomes. Many of the procedures are now done through robots. You must have heard the robotic surgery. Then the precision has increased. Then the minimal access surgeries are there. All this has actually improved because the technology has advanced. With the EHR, we have much more information which we can now process much faster and can take decisions real time to improve the quality. For example, if the average length of stay, I can see real time if the average length of stay is, going beyond what we decided that this is the optimal based on the industry standard. And if it, for some reason, in a month or in few months, it crosses that line, then we can know immediately, and then we can actually use the technology to reduce the average length of a stay. For example, in our hospital, what we did, even it is a government hospital, what we did that for every department, we started tracking the average length of a stay. And if the patients stay for certain diseases, if that was beyond 7 days, we were doing a very simple thing, that we were reminding the treating physician and the surgeon that here is a patient whose stay has crossed 7 days. And this was an automatic SMS and email from the HIS, that is the Health Information System. And with just a request that please review. If the patient requires continued admission, that's fine. If not, then please take an action. Because many times in public sector hospitals, it happens that the patients are a patient remain and sometimes discharge is delayed. So it actually reduce the average length of stay by improving the discharging process. And AI nowadays, you all must be using the large language models nowadays, and the AI's integration in the times to come with the hospital HIS system can be used for so many newer things to improve the overall performance of the hospital. Now the quality management system ecosystem, there are these pillars to this. I always say that pillars of the clinical excellence are there. One is the quality control. One is the second is the quality assurance. And but what we should as a healthcare administrator aspire to have is the total quality management and then this continuous quality improvement. Let's understand with this slide. So there is what is the difference between the QC, QA, and TQM? So QC is majorly you will see where the product is in some physical form. In our healthcare system, the product is a service. It's not something that we are producing, for example, let's say a car. So quality control is mostly where the product is there, whereas the quality assurance is the process oriented. The TQM actually addresses the whole culture and framework, and we focus on the culture of the organization, the frameworks, and then we try to improve them so that the ultimate outcome that is required is improved. The primary focus in QC is defect identification. In QA, it is the defect prevention, whereas in TQM, it is the continuous improvement, that is CQI. The key activities are inspecting, testing, reviewing. In quality assurance, it is auditing, training, and documentation. Now, auditing is also a very important part, plays a very important role in improving the quality of various initiatives in the healthcare. For example, the medical audit that we talk. Medical audit can be done for the documents, and the medical audit can also be done for the various procedures. For example, if you want to do a medical audit for orthopedic procedures and you take, let's say, the total hip replacement, you can actually see what are the outcomes after how many days patients were, made mobile, how many complications did happen, how many patients actually had a secondary infection, etc. So these audits actually help you to tell how good your outcomes are and where are the deficiencies that are to be plugged. Then the TQM we use for strategic alignment, total employment, and the total employee involvement. Some of the examples are for the QC, checking sterility of surgical instruments before use in the CSSD. We use two types of indicators for it. You must be told already, or if not, then whenever the CSSD module will be taught. There are two types of indicators. One is the biological indicators, another is the chemical indicators. The quality assurance is implementing the infection control protocols, and there are so many other protocols that you implement. You can actually do the quality assurance in that. And the TQM you use to deploy a hospital-wide PDCA, that is a plan, do, check, and act culture. There are 7 principles of the TQM, and the first and most important is the customer focus. We prioritize the patient needs because we have limited resources, and the time is one of those resources. You may not be able to do everything, but if you prioritize on the customer's focus. For example, in today's class, we are prioritizing the unit 11 and 12 over unit 9 and 10 because you as a customer wanted it, right? So focusing on what the customer wants and prioritizing those needs is important. Leadership plays a very crucial role. And it can, make or break the TQM. If the leadership is subscribed to your idea, is subscribed to the quality improvement, things become easier. Otherwise, to get the resources, take the people on board becomes even more difficult. Engaging the people, because ultimately in healthcare, people are most important, right? We are not a factory where we are, dealing with the robots, or we are dealing with some machines which will produce something. It's the people who are providing all these services, and you know, having them on board, having all the stakeholders understand the core philosophy of TQM, CQI, and the hospital's overall goal to achieve that is very important. Then the process approach, managing the interconnected activities, because uh, you must have heard that hospitals are matrix organizations where it's kind of a zigzag. You know, one person is governed or by, you know, monitored by multiple people. So then in any matrix organization, the chances of conflict are quite high. So the managing these processes becomes even more important. Then relentless pursuit of perfection through improvement is important. Evidence-based decision making, because as I mentioned in the earlier slides, we want to have desired outcome, but that outcome has to be a evidence-based, based on a evidence-based decision making. And then the relationship management, optimizing a stakeholder network, uh, because how will you come to know what the patient want? Having the feedback from the from your customer, having that relationship with your customer, and you are also customer to few people. For example, the vendors who are providing you the different types of materials. If that could be your consumables, that could be your equipments. As I said, that it is important to have quality input to provide the quality output. So that relationship management with those stakeholders where you are a customer to them, so that they provide you not only the quality inputs, but the timely inputs when you require is important. So the QMS implementation is like from strategic definition to stakeholder engagement to process standardization, then execution and training, and then the validation loop for it, and then you continuously adapt that. So for example, strategic definition is define clear objectives and scope. For example, target a 20% reduction in hospital-acquired infections. Now, hospital-acquired infection is entirely a different class, but you know, I have just mentioned 20%, but reducing it 20% is a lot. But first step is whether you are even, you know, registering it, whether you are measuring the hospital infection rate or not. That is the starting point. Many hospitals in this country even don't measure the infection rate in their hospitals. Then the stakeholder engagement I have already mentioned. The process standardization is important. For that, you can develop the SOPs, and if you are going for an standardization, sorry, the accreditation, then you in any case have to standardize your processes, and you have to have written SOPs for those. Execution and training. Training is very important. Hand holding and training and continuous training is many times needed, and the monitoring is needed because people keep changing, the processes keep updating, the SOPs keep updating. Communicating that and providing the commensurate training to the healthcare staff is very important. Then validation loop, conduct independent quarterly internal audits and monitor performance indicators. Um, if something is not measured over the period of time, you would find that because it has not been measured, because it has not been monitored, there will always be some type of deterioration in that. So if you have implemented something, don't forget it. Make sure that while you are preparing the SOP, it includes the evaluation process and the monitoring, how these things will be monitored in time bound manner, and what will the periodicity of that monitoring. Continuous adaptation, implement corrective actions to address non-conformities and refine based on data, and sometimes refine based on the feedback from the stakeholders. That feedback can be from your staff, that feedback can be from your patient, or you did an audit and you came to know something. So be open to changing the SOPs and your processes. So this is just a different way to put it, what I just now said, because this is there in the manual. So define objectives and scope, engage stakeholders, develop plan, select the software if needed, conduct process mapping, train the staff, monitor the performance, conduct audits, implement correction measures, and review and improve it again. So this is again another way to put it, because what portions are included in which type of a strategy. So the leadership commitment and the policy and objectives part, the governance. And let me tell you, many a times when we see whether this is at national level, whether it is at the state level, or at a hospital or an organizational level, it is the governance that we are actually talking about. कि ये अच्छा नहीं है या अच्छा नहीं है. The governance defines almost everything, because it's the governance that makes the policy, it's the governance that makes the monitoring system, and it's the commitment of the leadership that actually leads to the changes. No doubt stakeholders involvement, no doubt the inputs and everything is important. But if we have everything, but we do not have the committed leadership and the policies and the governance, then the outcomes may not be as desired. So the process management, document control, training and competence comes under the operations part. And the performance measurement, audit, stakeholder feedbacks is under the evaluation, and then the continuous improvement is the corrective and priority actions are taken, and the continuous improvement is done. So from traditional quality assurance in healthcare nowadays, we talk of the continuous quality improvement, because in healthcare, it's not just the one-time job. And the patient is also coming to us again and again and again. And he might have come once for a surgical procedure. Then he will come for the follow-up, and then he will come again. So the quality has to be maintained every time, and then the quality has to be a continuous loop. So an ongoing systematic data-driven effort utilizing teamwork and the frameworks like PDCA to continuously enhance the processes. So PDCA, some of you or all of you might have been aware, but I'll describe it in a small. And some of you might have been done projects on the PDCA cycle. If not, you can think of doing the PDSA or PDCA cycle in your internship or in your hospitals, wherever you are working. So first thing is to identify problem and design a solution. So you're planning. Everything starts with conceiving something, and the conceiving is in the brain, and then you plan on the paper, right? So you have identified a problem, or someone has informed you about a problem. That could be a patient, that could be a staff. Create a standardized discharge checklist and assign a coordinator to reduce delays, for example. Now, once you have planned, you will like to implement it. So you will do something, implement the changes on a small scale. Then you have to analyze it. You study it, measure what you have implemented, and then based on those feedbacks, you then again act, change your plans, modify your plans, and then you keep doing this cycle. It's not just one-time cycle. You keep doing these cycles on the multiple time, and you will find that the initial problem that you have identified, it has been improved a lot over the period of time. And if still it has not been addressed completely, then you do a deep dive and root cause analysis, why there are things that despite your strategy, despite your plan, despite you implementing things, still you are not able to achieve the desired outcome. So you have to, again sit on the table and redraw where are the things that require your special attention. These two terms many a times are used together, although they are entirely different. One is the lean and another is the Six Sigma. Lean is basically what we are doing is that we are reducing the waste in the system, and that waste could be anything. For example, I discussed about the waiting time. Waiting is a waste and should be reduced as much as we can. Repeating the same processes, wasting your energy on same process, or your process design is in a way where there are redundant steps that can be removed. Those redundant steps are unnecessarily a burden on your resources. So maximize the value by defining the value stream from the patient's perspective and eliminating non-value adding waste to improve workflow efficiency and increase the productivity. A very small example I give you. You all must have heard about the Nightingale ward. That Nightingale ward was a ward in which the beds were parallel to each other, and then the nurse station was at one end of the Nightingale ward. This was the initially the way hospitals were designed. The major problem in this was that the nurse had to walk a lot in that ward, because to reach to the last patient, which is on the other side of the ward, she has to go from the nursing station to that patient and then come back. And in a shift of 8 hours, walking too much in the ward was actually leading to the burnout and the other types of problems, physical strain, all that. So it ultimately lead to the modified Nightingale's ward, where the nursing station was shifted from one side of the ward to the middle of the ward. Now it had its own different problems, that now the nurses are within the middle of the ward, although now they have equal distance to all the, or not the equal distance, but the distance to the farthest patient is reduced. So then it was then further changed to the Riggs pattern ward that you would see in many of the hospitals now. So I'm just giving you one example how you reduce the unnecessary waste that's in the system, and there are so many examples to these. So lean methodology actually helps you in reducing the waste. And then there are different types of tools for that, for which a separate class is required. There is 5 years tools, and there are so many others. Now, Six Sigma methodology is basically about reducing the variance. That means you have decided a standard of a quality, and you want that the output should always be of that quality. It should not vary from that, and vary to a Six Sigma extent only. So 1 in a million, right? So this is basically a product outcome strategy where you want the best product or the quality product. This is implemented nowadays in the processes also, and service industry also. So how it is done? It is basically 3.4 defect per million opportunity. So it's a Six Sigma. So once it's called the DMAIC cycle. You define, you set the project goal, then you measure, analyze, improve, and control. It is similar to PDCA, but here the objective of your is that you want to reduce the variance, so that your product or your service has a defined quality every time it has been given. There are different types of waste in hospital, but because the manual has discussed about these 8, so I'll be discussing this. One is the overproduction. This could be in many ways, when these are preparing medications or ordering tests earlier than necessary, or maybe over ordering where you in the inventory. So stockpiling surplus, as you can see just below the overproduction, the medication supplies at risk of expiring. And this is a major problem in many of the public sector hospitals, where not just the medication and the consumables, but even the underutilization of the many equipments that are bought. So for which there is a concept of equipment audit. Equipment audit actually helps you improving the quality of your services pertaining to that equipment. On one side, there might be equipments that are less utilized, and on the other side, you might have the equipments that are already, working at its maximum capacity. That could be a CT scan or an MRI scan, where you have a large waiting of, let's say, sometimes in the public sector up to 6 months waiting just for an MRI. So both these situations are not good, because these are compromising the quality. Now waiting could be because of the lack of the resources lack of the processes or inefficient processes. For example, as I mentioned, in case of MRI, it may be the number of patients are more and the number of MRIs are less. Even if you buy another MRI, you need human resource to run this MRI. On the other side, there could be inefficiency in your system where you have enough inputs, you have equipment, you have people, but your processes are not efficient. So something that can be done in 2 hours, you are actually doing in 3 hours. Or, for example, the turnover time in your OT, where the turnover time between one case and another case is unnecessarily higher than the industry standard. So this actually leads to the inefficiency in the system. The motion, the nursing walking excessive distances to retrieve basic ward supplies, or not just the nurses. This could be applicable to many other stakeholders. So that's why you must have seen many of the now hospitals have the chute system to transport their uh, samples, drugs, etc., and it reduces the motion of the staff. Transport moving patients unnecessarily between multiple distant departments, scheduling them, scheduling a transport in a way that reduces the overall time. If I have to send the patient from my ward to two different areas, I schedule it in a way so that there is less number of zigzag of motions. Defects, there are different type of defects, whether it is medication error, surgical site infections, misdiagnosis, and we discuss a lot about implementation of the surgical safety checklist, the the international patient safety goals. If you have heard about them, one was the about the surgery, then the clean hands, um, and the surgical site infections also. So we need to reduce the medication errors. We need to reduce different types of errors that happen, whether it is in the ward, in the OT, and a lot of it happens because of the fatigue. The healthcare workers fatigue, healthcare workers, who are overburdened in comparison to, or if they are working overtime. So all these are interconnected. So as a healthcare administrator, we need to understand what actually is leading to such type of errors, and whether or not we are addressing the root cause of the errors or not. Addressing the cosmetic things may help you in short run but would not help you in long run to improve your quality. So always look for what is in the root cause and try to address that. Then the extra processing, forcing patients to fill out the same demographic forms repeatedly, and I'll show in when I discuss about the legal issues about the labor laws. You must have heard recently the government actually repealed 29 labor laws and combined them into 4 new labor codes. You may have this type of opportunity, so many opportunities in your hospital where nurses are unnecessarily filling the forms, nurses are unnecessarily filling the registers, or are doing some online reporting which is not required or can be clubbed. So that extra processing can be looked into, and that waste can be removed. And underutilized talent, as I said, underutilized equipment, similarly underutilized talents. You are not utilizing them effectively or efficiently, or you are utilizing their talent, not utilizing talent to the fuller extent. So that also you need to look into, because that is again a waste of your talent. So the improvement engines metrics is the CQI, the Six Sigma, and the Lean. And if you combine them, if you work on them in your hospital, then you can have a better quality outcome. Uh, Now let's discuss a little bit about the accreditation. As I mentioned, there are mandatory requirements that we need to fill. Some of them are legal that I'll discuss when I discuss the legal part. Then there are certifications, then there are accreditations. Accreditation um, uh, has taken a big leap in last almost 15 years, especially in this country. And nowadays, to be the CGHS empaneled hospital, you should be accredited to one of the accrediting bodies, NABH. And not only NABH, NQAS you must have heard, and then there's Suman, Lakshya. There are so many other quality improvement initiatives are there, which are a way of kind of accreditation only. Pure accreditation, when we are discussing, it's basically voluntarily agreeing with with the standard protocol defined by an agency that we will follow it, and we submit it to you know periodic review and corrections. So it's an external independent evaluation certifying that a healthcare organization meets stringent standards of quality and safety, which are based on certain standards. You must have heard that NABH has now sixth edition of its standards. So what accreditation does, it ensures quality and safety by adherence to global best practices, enhances patients' confidence. When you know that a hospital is NABH accredited or a JCI accredited or has an NQAS, then you know that, okay, there it meets a certain standard. It has been examined independently by external agency and is being monitored continuously or periodically, so it improves the confidence of the patient, promotes continuous improvement. Then it is a motivation also within the hospital. Otherwise, that if you are not NABH accreditation, if you do, it's good. If you don't do, then again, no, there is no motivation unless it has been forced. But when you are an NABH accredited or NABL accredited, because there are labs in this country which are NABL accredited, so there is a motivation, continuous motivation to attain to those standards or maintain those standards. It's facilitate regulatory compliance because it is not only compliance to the accreditation standards. As a byproduct, you are compliant to all the legal requirements also, because that is one of the requirement for the accreditation of the NABH or JCI. As I mentioned, there are JCI, there is NABH, and to different regions and the countries have their own accreditation bodies. And then there is ISQA also. ISQA basically accreditates the accrediting bodies. For example, NABH is accredited to ISQA. So it's not just the hospital accrediting bodies, but then there is an accrediting body for those accrediting bodies also. So there is internal excellence, there is external review, it leads to public trust and the verified quality. Now, how this accreditation is done? It itself is a whole class, but in short, it starts with a plan. As I mentioned, everything starts your desire or you conceive. So when you have this commitment from your leadership or a mandate from your leadership that we have to accredit our hospital, you start the preparing for it. Secure leadership commitment. Then you submit the application for operational documentation. And first thing you do is the self-assessment. You evaluate your internal policies. Then you may find that, okay, these many standards we are already meeting. These are the standards for there are. When your self-assessment you find non-compliance, we call it NC. That there is an NC for this standard. Then you start fixing those gaps, train your staff, implement the SOPs. If there is lack in the documentation, you prepare the documentation. And then you prepare for your external on-site survey. So the observers or reviewers will come. They will assess your site, and then they will give their report to the accrediting body. You will receive the feedback, compliance reporting, a decision whether you can be given accreditation or something more has to be done, whether another visit is required or not, or it is just the based on the documentation it will be done. So those decisions you will get. And once accredited, you have to continuously monitor and periodically renew your accreditation. Now, a word about the newer things that are happening in the quality management and predictive analysis and AI. To some extent, I already mentioned there are emerging innovations, telehealth, blockchain, robotics. Especially, I worked in a US hospital almost 10 years ago, and I was very surprised at the times to see that the narcotic drugs were being delivered by a robot to the ward. So the robots were delivering the narcotic drugs, and the sister could only open it with the fingerprint. So nowadays, robots are almost everywhere in many hospitals in the world. At the airports also, you will.
മതി എങ്ങനെ കൊണ്ടത് കളയണം അവിടെ അടുക്കളയിൽ ക്ലാസ്സിലുണ്ട് അയ്യോ
Just now mute yourself.
Okay, thank you. So another thing is that the improvement in the EHR, the initial earlier models of EHR, not as robust or good as nowadays you see. Some of you must have heard about the Epic. Epic is still not here in India, but whatever we are using in India, they are still very good EHRs. I have seen in last 20 years the evolution of electronic health records, and nowadays they are better prepared for this predictive analysis and the AI. It will take some time, but the way that things are, advancing, the pace of advancement is very, very fast. So be prepared that in times to come, we will be using AI at a much higher scale than what we are using right now. So that was all in short, I would say, based on the Unit 11's contents I have prepared. And before I go to the next topic, that is Unit 12, if you have any questions, any comments, any observations or your experiences that you want to share, you are more than welcome to share. Just raise your hand first so I can schedule you. Mr. Pandey, please go ahead.
Yes, sir. I am actually Dr. Colonel Madan Mohan Pandey. Served in Army for 30 years as surgeon, trauma and laparoscopy. Then I was at Medanta Ranchi as a consultant as well as medical superintendent. And in the latter part, 4 years back, I established Tata Cancer Hospital over here in Ranchi.
Wonderful.
And then I have already done postgraduate diploma hospital health and health management.
Okay.
And this is my academic interest, which has taken me with you or for this MBAHCM course. So many of the things I have already employed in the hospitals as administrator. As you were telling about the wasting of time by the nursing officers or nurses, like if a cart or trolley can be arranged where she can put the medicines for all the patients in the ward, and if the wardrobe is somewhere else, and so this I in fact employed in fact as a practice, and that saved a lot of time in this cancer hospital, because initially when we started we had just a handful of nurses who were trained in treating cancer patients. We got it, in fact, trained them at TMH Mumbai, but the numbers were very less. So we had to manage with that numbers which were provided to me or it was available to me. So this was the one instance, and it was a wonderful communicating with you. And over few more days, in fact, we'll be interacting with you. If someone else wants to ask something, sir is open, and already he has given. What I can say is note the normal presentation, sir. It is very advanced one, which we have seen it, and so far we have not seen it earlier also.